regarding a preoperative evaluation and management for a vascular surgery patient. So coming to the general assessment risk, usually in routinely we have to do detailed history, physical examination, blood analysis, ECG, complete blood count, electrolytes, serum electrolytes, baseline creatinine, GFR rates, glucose concentration, etc., and coagulation profiles, etc., as a basic assessment. And usually preoperatively, the overall assessment of health can be by ASA classification, which includes the functional status and the anticipated physiological strain of surgery. It is classified routinely from ASA 1 to ASA 6. So coming to the detailed evaluation for each systems. So first I am starting with the cardiac evaluation and management. So major vascular surgery, they are associated with post-op MI in 1 to 6%, and more in case of open aneurysm repairs, etc. And post-op MI increases the risk of 1-year mortality from 5% to 37%. So, okay. So coming a detailed cardiac history, a physical examination, and a baseline ECG is a routine cardiac assessment for all vascular surgery patients. And for selected patients only, we'll do the advanced cardiac testing for elective vascular procedures. So the other testings are resting echocardiogram. So according to the American guidelines, they recommend the echocardiogram for intermediate and high risk vascular surgery patients. And it should be obtained in the preoperative period if there is any suspicion of decompensated heart failure, valvular disease, or structural heart disease, etc. But European guidelines, they recommend in case of only high-risk surgery patients. And the other thing is the stress test, stress echocardiography. This usually manifests a regional wall motion abnormality at the peak of the stress. It can be performed via exercise like treadmill or bicycle or pharmacologically. And pharmacologically based stress echocardiograms, usually they use inotropes like dobutamine commonly used. So stress testing is not indicated for all patients. It is indicated for intermediate or high cardiac risk patients with poor functional capacity. Routinely, it's not done. So coming to the major adverse cardiac events classification in a vascular surgery patient. So according to the 30-day major adverse cardiac events percentage, it is classified into low risk surgeries with less than 1%, like carotid endarterectomy or stenting in an asymptomatic patient, or intermediate risk vascular procedures like 1% to 5% MACE risk in angioplasty, peripheral angioplasty, endovascular aneurysm repair, etc., and symptomatic carotid surgeries, and more than 5% MACE risk in high-risk vascular procedures like open aortic surgery or amputation or thrombectomy, revascularization procedures. So coming to the functional capacity, this is the main thing for the cardiac assessment. So it is a metabolic equivalent, which is defined as a resting metabolic rate. So 1 MET is the amount of oxygen consumed by a 70 kg 40-year-old man at rest. So approximately value is 3.5 ml oxygen per kilogram of body weight per minute. So common activities, usually we do request 4 METs, including walking, climbing stairs, etc. But at least requires more than 10 METs. So asymptomatic patients with the functional capacity of 4 to 10 METs, those with a normal stress test within 2 years, or those who have had coronary revascularization within the 5 years, do not need any further cardiac testing. So patients with, and other thing is the patients with pacemaker or implantable cardioverter defibrillator. This requires reprogramming because of the use of monopolar cautery during the open surgeries, and reprogramming is required. And other thing is external defibrillation equipment with transcutaneous pacing should be readily available in the operating room for these patients with pacemakers. So this is the revised cardiac risk index. It is a tool to estimate the risk of cardiac complications after a non-cardiac surgery. It includes basically the 6 predictors you can see here, like CVA, diabetic mellitus requiring insulin, serum creatinine more than 2, coronary artery disease history, high-risk surgeries like chest and abdominal surgeries, etc. And based on the thing, the total score ranges from 0 to 6, low risk to moderate and high risk, etc. To indicate the cardiac complication. So coming to the stepwise approach of perioperative cardiac assessment for a coronary artery disease patient. So this I will show with this diagram. So when in a vascular surgery patient with a known risk factor for coronary artery disease, the step one is whether you have to classify whether the surgery is a emergency or not. So if the surgery is emergency, then determine the clinical risk factors and which influence the perioperative management, and proceed with the surgery with monitoring and appropriate management strategies. And if it is not an emergency, then you have to assess the acute coronary syndrome symptoms. So if there is any symptoms of acute coronary syndrome, then you have to evaluate further the patient before the surgery. So you have to get a cardiology evaluation and manage according to the guidelines of medical therapy and based on the STEMI or STEMI clinical guidelines. So if the acute coronary symptoms are not present, then you have to estimate the patient with the perioperative risk of MACE. The MACE risk is calculated here, and based on the risk, it is classified again. With low risk patients, you don't need any further testing further, and you can proceed with the vascular procedure. But if there is any elevated risk of MACE, then you have to assess the functional capacity, which I said earlier. So moderate or greater than 4 meds, that is classified again into excel and more than 10 meds, or 4 to 10 meds. These both does not require any further testing because it is reasonable to proceed with the surgery indicated. If there is the functional capacity is not assessed, poor or unknown functional capacity, that is less than 4 meds, then there comes the decision making. So in this situation, you have to discuss with the patient and the other team members, like the patient has to take a decision further. Like the decision to perform an original surgery or the willingness to undergo a CABG or a percutaneous intervention based on further testing. So if you do a further testing, if it comes out as positive, he would be willing to proceed with a coronary revascularization or a PCA, like a CABG or a PCA intervention. So if the patient is willing to proceed further, then you have to go for the stress testing. And if the based on the reports of the stress testing, if it is abnormal, you have to definitely go for a coronary revascularization first and then proceed with other intervention strategies. If it is normal, then you can proceed with the vascular procedure. So if the patient is not deciding to go for a further testing, then you can either proceed with the guidelines of medical therapy and do the procedure, or you can try better to go for an alternative strategy like a non-invasive treatment or a palliative procedure. So this is the stepwise guideline for the cardiac assessment. So coming to the perioperative medical versus interventional therapy for a cardiac disease. So beta blockers. So use of beta blockers has long been a standard care in most of the patients with cardiac disease undergoing our procedure. So two trials I am sharing here, that is the POISE trial and the Dutch echocardiographic cardiac risk evaluation decrease score trial. These both trials showed reduced cardiovascular risk events in patients with high cardiac risk indices when using beta blockers. And so based on this, the beta blocker, if the patient is using chronically, it has to be continued. So if it is not discontinued, there will be a chance of rebound tachycardia for the patient. So in patients with intermediate or high myocardial ischemia risk or preoperative risk stratification test, or 3 or more the reverse cardiac risk index risk factors, then it is reasonable to begin a perioperative beta blocker, but it should be started in advance to the surgery. So to assess the safety and tolerability, beta blocker therapy should generally not be started on the day of surgery, just prior to the surgery, because it can develop hypotension, bradycardia, and ischemic strokes. So then coming to the statins, there are several studies which show the effectiveness of the preoperative statin therapy. Fewer postoperative cardiovascular events are noted after the use of statin. So it may be due to the pleiotropic effects on endothelial function, reduction in vascular inflammation, and stabilization of the plaque. So guidelines recommend patient undergoing major vascular surgery should either be continued with a high intensity statin on home, or it should be started on a high intensity statin in the preoperative period itself. So coming to the dual antiplatelet therapy, several studies have demonstrated overall safety of continuing the dual antiplatelet in vascular surgery. Still, there is a higher risk of bleeding, but it is in exchange for a reduction of cardiovascular events. So duration of dual antiplatelet therapy is dependent on the indication for what it was started, like acute coronary syndrome, where PCA technique like bare metal stent or DES is used or not. So if the risk of surgical bleeding is believed to be very high, elective vascular procedure should be postponed until the dual antiplatelets can be safely withheld. So the dual antiplatelet, usually it is continued particularly during the first 4 to 6 weeks following the coronary stent implantation. Unless the risk of bleeding outweighs the risk of coronary stent thrombosis, you should not stop it. Consultation with the cardiologist is appropriate for prior discontinuation of the dual antiplatelets. So coming to the role of coronary revascularization, generally it is recommended for left main coronary disease or triple vessel disease or complex anatomy or high risk comorbidities. The CARC trial, coronary artery revascularization trial, shows patient with stable coronary artery disease coronary artery revascularization before elective vascular surgery procedure does not improve the cardiac outcomes, long-term outcomes, or does not reduce the short-term postoperative outcomes such as death or MI or hospital stay. So coming to the hypertension management. So high morbidity and mortality has with both hypotension and hypertension. So for a non-cardiac surgery, recommendation is maintain a BP with 90% to 110% of baseline. For patient with a low baseline BP, the maintain a MAP more than 60. Patient with a high baseline BP, like systolic pressure more than 130, then recommend to maintain the systolic pressure in less than 160 range. Chronic hypertensive medication should be continued, as I have already told, during the preoperative period, and exception of which is AC inhibitors and ARBs. So intraoperative hypotension in patients who receive ACs and ARBs on the day of surgery has been associated with increased risk of all-cause death, stroke, and MI. So this should not be continued. Coming to the pulmonary evaluation. So pulmonary complications are reported in 1 to 2% minor surgeries and 20% in upper abdominal or thoracic operations. So pre-op pulmonary evaluation is important. A detailed history, identify the risk factors like smoking history, oxygen dependence, exercise tolerance, unexplained cough or dyspnea should be done. Physical examination to identify the patient as at risk should be done, like the examination for viscous, crackles, prolonged respiratory phase, etc. So these are the risk factors for post-op pulmonary complications. This includes emergency procedure, age over 65, any congestive heart failure history, chronic obstructive pulmonary disease, and based on the functional status, smoking, operative time more than 3 hours, and ASA class more than 2, type of the procedure and surgical site like thoracic or upper abdominal procedures, and obstructive sleep apnea. It is undiagnosed in 22% of the adults, and chance of reintubation, hypoxemia, etc. are high. So asymptomatic patients do not need routine preoperative chest X-ray. Chest X-ray is recommended for patients with known cardiopulmonary disease, age more than 50, undergoing any major surgery, abdominal, thoracic, or abdominal aortic aneurysm surgery. This is just a classified score for obstructive sleep apnea. It's called stop bang score. Stops like STOP, snore, tired, observed, high blood pressure, and bang includes BMI more than 35, age over 50, neck circumference more than 40, and male gender. And each points add on to the score, and it classifies into low risk, intermediate risk, and high risk. Another thing is the low serum albumin. It is a powerful independent marker of increased post-op pulmonary complication. So the next thing is pulmonary function test. It is not routinely done. It is done useful in patients with underlying lung disease where clinical evaluation is either insufficient, or in patients were unable to determine their baseline lung function. For major surgeries like upper abdominal surgery, thoracic surgeries, etc., we require a pulmonary function test. So if a patient is identified as at risk for pulmonary complication, the risk reduction strategy should be started. So this includes smoking cessation. So at least 2 weeks prior to the procedure, complete smoking cessation should be done. So then the respiratory physiotherapy, respiratory muscle training, optimization of nutrition status, etc. are the other strategies. So patients who currently smoke have twofold increase of risk of postoperative complication. Smoking abstinence can reduce the rate of such complication. Beneficial effect of smoking cessation is including improvement in ciliary function, decrease in sputum production, which occur gradually over a period of several weeks. So coming to smoking cessation, physician counseling can be done. Then add on to it, pharmacological strategies are there to quit the rate of smoking. These all includes nicotine replacement therapy, bupropion, hypnosis, varenicline, and other second line agents like nortriptyline, clonidine, etc. Then history of bronchospasm or COPD is there. The guidelines suggest to use inhaled bronchodilators or beta-2 agonists or anticholinergics as a mainstay for symptomatic therapy for patients with bronchial hyperactivity. This should begin at least 5 days before the surgery itself. And systemic or inhaled corticosteroids have been recommended in patients with FEV1 as less than 80% of predicted if the planning for general anesthesia. So lung expansion techniques such as incendiary spiral, chest physical therapy, cough, postural drainage, ambulation, positive airway pressure have been used to limit the postopulmonary complications. Coming to the renal evaluation and management. Renal evaluation, 1/3 of the patients suffer from stage 3 or higher CKD in vascular surgery. So kidney function test must be evaluated pre-op and rule out the presence of renal failure symptoms, signs of hyperkalemia, and volume status should be assessed, anemia and bleeding risk should be assessed. A baseline creatinine level, glomerular filtration rate should be obtained. And if a patient is already on dialysis, examination of the vascular access site should be inspected for signs of infection and functionality pre-op and post-op. So important to evaluate their medication regimen and adjusting the dose of medication choices as necessary to further avoid the renal damage. In some cases, we should need to postpone surgery until the patient's kidney function is stabilized or improved. And hyperkalemia has to be corrected prior to the procedure in the CKD patients using K-Bain sachets like orally to remove the excess dose of potassium. Then insulin and intravenous dextrose, calcium carbonate for cardiac stabilization, intravenous bicarbonate, and dialysis. So patients maintained with dialysis should undergo dialysis the day before surgery in a non-emergent situation. Correction of electrolytes, acid balance should be achieved before the surgery itself. It is also important to assess volume status and manage any fluid imbalance prior to the surgery. So optimizing the volume status through diuretic therapy or other interventions may be necessary to ensure the patient is in optimal stage for surgery. Then in CKD patient, the problem with the bleeding problem is because of uremia associated platelet dysfunction. This dysfunction occurs due to impaired platelet aggregation, decreased adhesion, and impaired release of platelet granules. These changes can result in decreased ability of platelet to form clots and stop bleeding, leading to increased incidence of perioperative bleeding. Patients may be on antiplatelets or anticoagulants also. This increases further bleeding complication during surgery. So several options are there to improve the platelet functions in patients with uremia-associated platelet dysfunction. This include one is dialysis to remove the uremic toxin. Then desmopressin is a medication that improves platelet function by releasing 1 Willebrand factor. Cryoprecipitate transfusion of red blood cells or platelets, which increase the number of functional platelets in the blood. So renal dysfunction can cause changes in blood clotting factors also. This can lead to prothrombotic state also. So uremic toxin can cause impaired platelet function leading to bleeding, and platelet clotting factor dysfunction can cause risk of thrombosis. So risk of thrombotic complications such as stroke and MI which can also be increased in patients with renal dysfunction. Therefore, close monitoring and individualized management is essential to optimize patients' outcome in CKD. So coming to the drugs in renal patients, antiplatelets can increase the risk of perioperative bleeding. So stop prior to surgery if feasible. In addition to that, certain drugs have minor platelet effects. These includes diphenhydramine, antihistamine, non-steroidal anti-inflammatory drugs, benzodiazepine, cimetidine like histamine H2 receptor antagonist, etc. In patients with renal dysfunction, the clearance of heparin also is reduced. So decreased intraoperative heparin dosing should be considered in these patients. However, the dose of heparin should be carefully balanced against the risk of thrombotic complications. So other thing is in renal failure patient is anemia because of decreased production of erythropoietin. If necessary, RBC red blood cell transfusion before emergency surgery, but unnecessary transfusions are avoided in renal failure patient because of antibody formation or hyperkalemia. If surgery is elective, it should be delayed until erythropoietin can be administered and hematocrit allowed to increase in response, or you can use intravenous iron vitamin B12 oral folate to improve the hemoglobin anemia and for the treatment of anemia if the surgery is expected to have high blood volume loss. Then coming to contrast-induced nephropathy, it is another significant problem as more patients are receiving iodinated contrast medium. The strategies to reduce this is avoiding iodinated contrast by using alternative imaging techniques like MRA or ultrasound, limiting the volume of contrast use, using only non-ionic or low osmolar agents like iodixanol, Visipac, complete avoidance of iodinated contrast by using carbon dioxide, and judicious pre-procedural hydration and with isotonic saline. N-acetylcysteine is a potent antioxidant and a precursor of glutathione. It is a key antioxidant. It prevents a contrast-induced nephropathy through its ability to scavenge free radical and prevent oxidative stress in kidney. In addition, N-acetylcysteine has shown to increase the renal blood flow and decrease the renal vasoconstriction and contribute to its protective effects. But there is conflicting and insufficient data to recommend this use of this N-acetylcysteine or IV sodium bicarbonate, ascorbic acid, statins, low-dose dopamine or phenoldiazepam to reduce the incidence of CIN. The use of gadolinium-based agents such as those using magnetic resonance imaging should be avoided in the setting of compromised renal function because of development of nephrogenic systemic sclerosis. It is a fatal syndrome that involves fibrosis of skin, joints, eyes, and internal organs. Coming to diabetic evaluation and management, a complete diabetic history of episodes of diabetic ketoacidosis or hyperosmolar coma should be noted down, and evidence of diabetic autonomic neuropathy which predispose to perioperative hypotension or gastroparesis and aspiration risk also be noted down. Then hyperglycemia during the perioperative period, it can cause increased rate of complications post-op, worse outcomes, high rate of 30 days mortality, MI, stroke or renal failure, wound complications mainly with infections and longer hospital stays and major adverse events. So strict glucose control can significantly reduce the risk of wound infection and may improve the outcomes, all these outcomes in vascular surgery. So glucose control should be attained weeks before the surgery. So HbA1c is a diagnostic tool for assessing this long-term glucose control. It should also be considered in non-diabetic patients also. Studies demonstrate that even in non-diabetic patients, higher mean glucose and higher glycemic variability is associated with longer stay in hospital and risk of complications. So optimizing glucose control in all patients undergoing surgery, regardless of the diabetic status, to improve the outcome. So recommended inpatient glycemic control is target glucose level of less than 200 in both diabetic and non-diabetic patients. And data are lacking in more intensive glucose control postoperatively or specific HbA1c targets preoperatively. OHA should be withheld in the day of surgery. Hyperglycemia can be corrected with insulin. Metformin should be stopped 24 hours before the surgery to prevent lactic acidosis if the patient's renal function becomes compromised. Specific sliding scale insulin regimens are utilized on the basis of the hospital-based guidelines. While available data point to hyperglycemia being a risk factor for complication, trials have failed to support the concept of intensive blood glucose control, improving perioperative outcomes. So the use of intensive insulin therapy has been demonstrated to have no effect on mortality, sepsis, or wound infection. Coming to adrenal evaluation and management. Patients chronically treated with steroids are at risk of post-op adrenal crisis. So history should be properly made to screen for steroid use, other causes of any secondary adrenal insufficiency like hypothalamic or pituitary dysfunctions. And primary adrenal insufficiencies may be present in tuberculosis, acquired immunodeficiencies, and autoimmune endocrine syndromes. So all these should be noted down in history. And adrenal insufficiency evaluation is done in patients who are taking more than 5 milligram of prednisolone per day or its equivalent, less than 5 milligram of prednisolone, but in the evening, and patients who have discontinued glucocorticoids in the year prior to the surgery. So measuring a morning cortisol level or assessing the result of corticotropin stimulating test to help to identify adrenal insufficiency, and morning cortisol level below 5 is suggestive of adrenal insufficiency, while a level above 18 rules out the condition. 5 to 18 in patients with cortisol level between 5 to 18, corticotropin stimulating test can be done for further evaluation. Identification and treatment of adrenal insufficiency before surgery will reduce hypotension, electrolyte imbalance, or cardiovascular collapse perioperative period. The recommended stress dose regimen for patient receiving daily corticosteroid 5 milligram or more prednisolone or equivalent is hydrocortisone 100 milligram IV administered at the time of anesthesia induction, followed by continuous infusion of 200 milligram per day until the transition of double oral glucocorticoid dosing can be resumed. This regimen should be maintained for 48 hours post surgery and in some patients up to 1 week also. But patients taking less than 5 milligram prednisolone in the morning, treated for less than 3 weeks, taking less than 10 milligram of prednisolone every alternate day does not require any intraoperative steroid coverage in addition to their daily dose. Perioperative steroid use may be associated with impaired wound healing, increased blood glucose concentration, or increased susceptibility to infection, which should be taken care of. Recent meta-analysis, a single dose of perioperative dexamethasone resulted in no difference in risk of perioperative wound or systemic infection. Coming to anemia and coagulation assessment, anemia increases the postoperative morbidity and mortality. Ideally, pre-op anemia should be identified and treated if possible. Pharmacologically interventions are iron supplements, vitamin and folate supplementation, and erythropoiesis stimulating agents. Transfusion of blood preoperatively is limited to patients who are symptomatic or bleeding with severe anemia or poor physiological reserve with insufficient time to correct physiological abnormality. Most current guidelines recommend adhering to restrictive transfusion strategy when possible. Transfusion should be considered if hemoglobin level is less than 7 gram per deciliter, or if the patient is with symptomatic coronary disease, hemoglobin concentration 8 gram or less. For elective surgery, preoperative administration of erythropoietin, IV iron supplementation, vitamin B12, folic acid should be considered to boost the patient's red blood cell volume from the endogenous source. Autologous transfusion of previously banked blood, intraoperative auto transfusion can also be considered, but it is based on patient's condition, anticipated blood loss, or feasibility of this procedure. Coagulation assessment, most of our patients are antiplatelets or anticoagulations, so it should be routinely checked. Thorough medical history detecting the inherited or acquired bleeding disorders should be asked for. That would increase the risk of perioperative bleeding. And routine tests include an activated partial thrombopoietin time APTT, PTANR, or platelet concentration. And INR greater than 1.8 and a platelet count less than 50,000 have been associated with adverse outcomes and may need delaying of surgery or need correction before the procedure. Coming to venous thromboembolism prophylaxis and thrombotic factors, venous thromboembolism and its complication in surgical patients can be stratified based on the risk factors of the patient and type of operation. So patient's coagulation status, previous history of any thrombotic events, family history of DVT should be assessed. And any previous history of drug intake like anticoagulants or antiplatelets or any possible adverse reactions like heparin-induced thrombocytopenia or aspirin allergy should be noted down. And pharmacological prophylaxis include heparin, unfractionated low molecular weight, fondaparin, warfarin, antiplatelet therapy, and direct oral anticoagulation. Mechanical devices like graduated compression stockings, intermittent pneumatic compression, venous foot pumps are also effective modalities for prophylaxis of venous thromboembolism. So perioperative management of anticoagulation, it includes whether the need to discontinue any chronic anticoagulation, need of bridging the anticoagulation prior to and after surgery. So recommendations are for timing of cessation of anticoagulation prior to the surgery Warfarin should be held for 5 days, dabigatran 2 to 4 days, depend on the renal function, and direct oral anticoagulant for 2 days for high bleeding risk procedures or 1 day for low bleeding risk procedures, and antiplatelet agents 5 to 7 days for operations not requiring dual antiplatelets. So recommendation of bridging is bridging anticoagulation with therapeutic low molecular weight heparin or intravenous unfractionated heparin in high-risk patients, those with atrial fibrillation or risk of embolic stroke or systemic embolic events within the past 3 months, or mechanical aortic valve, mechanical mitral valve process, etc., or recent coronary stenting, etc. Bridging anticoagulation in patients not at high risk is unclear, and individual risk factors should be considered in that. Whether to bridge a patient for surgery as well as the decision to resume the anticoagulation after the surgery, it all depends on the risk of bleeding in the judgment of the surgeon. But in general, resumption of anticoagulation should occur 12 to 24 hours after the surgery. It is important to know the reversal agents also for the available for all the anticoagulants, including direct oral anticoagulants. When managing anticoagulation, bridging prior to use of anticoagulation bridging prior to the use of spinal or epidural anesthesia, the prophylactic low molecular weight heparin should be discontinued 10 to 12 hours prior to the placement of catheter, and it should be resumed 6 to 8 hours after the catheter removal. When using the therapeutic dose of LMWH, it should be discontinued 24 hours prior to the catheter placement, and it should be restarted 24 hours after the removal. So this table shows the reversal agents, mainly idarucizumab for dabigatran, andexanet alpha or 4-factor or PCC for apixaban, rivaroxaban, vitamin K for vitamin K antagonists, and protamine for heparin and low molecular weight heparin. And the doses is given. So DOAC should be stopped 2 days prior to the procedure with high risk, or 1 day high risk bleeding, or with 1 day for low risk. It should be resumed 48 to 72 hours after a high risk procedure or 24 hours after a low risk procedure. Postoperatively, anticoagulants can be resumed at preoperative dosages once the hemostasis has been ensured. Coming to infection evaluation and management. Active infection in the preoperative period should be identified because it can cause surgical site infection or perioperative decompensation. So common sources: urinary tract, pulmonary system, ischemic extremity with a wound, previously placed prosthetic material, etc. So history to elicit the signs of infection should be done, especially the wound examination, physical examination of chest, and the ulcers like open wound, any discharge or drainage or tenderness or erythema should be assessed. Then investigations include urine analysis, chest X-ray, white blood cell count should be obtained if indicated. And if infection is identified, surgery should be delayed if possible. Choice of antibiotic should be tailored based on the specific microbe or sensitivity identified from the culture. Perioperative prophylactic antibiotic administration is recommended for patients undergoing vascular surgery. And perioperative period, adequate volume replacement, the glycemic control should be implemented, and alcohol-based antiseptic agent should be used for skin preparation unless contraindicated. Antibiotic should be administered within 1 hour before the incision and discontinued once the incision is closed in a clean case, and clean contaminated cases if the drain is left in place. Acceptable prophylactic antibiotics include cephalosporins like cefazolin or cefuroxime. Clinda and Vango can be used as an alternative in case of allergy. Vancomycin is used in MRSA, chronic wound, dialysis patients. Preoperative length of stay is more than 24 hours. So it is antibiotic choices based on the institution-specific patterns. Antibiotic resistance is a growing problem, particularly with MRSA infection. So some preventive strategies include hand hygiene practices, implementation of contact precautions, recognizing previously colonized patients who have not met the criteria, and discontinuation of isolation, rapid laboratory reporting of MRSA, providing MRSA education to healthcare providers. Coming to nutritional evaluation and management, half of our surgical patients have preoperatively malnourished, and increased risk of postoperative complication because of that: impaired wound healing, pulmonary complication, longer stay in hospital, higher health costs, overall increased morbidity and mortality. So malnutrition is a commonly commonly seen thing, which is exacerbated by cardiovascular risk factors, diabetes, renal failure, chronic mesenteric ischemia, etc. So nutrition assessment should be performed in all our patients. History of weight, evaluating the weight and appetite changes and patient's functional status should be assessed. Weight loss of more than 5% in 1 month or 10% in 6 months should be is considered significant increase and it signify an increased risk of post-operative complication. Serum albumin is the appropriate marker for chronic protein status because albumin is the most abundant plasma protein and has a long half-life, making it a marker for long-term protein status. So hypoalbuminemia less than 3.5 is an independent predictor of major adverse events and death after open surgery. More severe hypoalbuminemia less than 2.8 days is associated with mortality, return to operating room, prolonged length of stay in patients undergoing bypasses. Therefore, monitoring of serum albumin levels before and after major vascular surgery can help identify patients at increased risk of adverse events and mortality. So, nutritional support like 25 to 35 kilocalorie per day should be provided with 1.5 to 2 gram per kilogram per day of protein. It increases the post-operative outcome and lowers the complication. So it should be particularly in those with severe malnutrition, like less than 2.1 albumin. Enteral nutrition is preferred than parenteral usually because it is safer and more cost effective. It is recommended that nutrition support will be provided at least 10 days to 14 days before the major surgery. Coming to the last topic, frailty assessment. Frailty is a medical term used to describe the state of vulnerability or weakness in older adults. It is not a disease. It is a multiple factor like age-related physiological changes, chronic medical conditions, cognitive impairment, malnutrition, and physical activity. This shows a decline in person's functional and physiological reserves. So how much a person is able to cope up with the stress of the surgery or recover from the surgery, illness, or injury is based on this frailty scores. So different tools are there. One is a clinical frailty scale, CFS, based on evolved from Canadian Study of Health and Aging. It is a summary. It provides a summary tool for clinician to assess the frailty and fitness. 9-point scale, and severity increases with the increase in the points. So this is a clinical frailty scale with visual chart also. 1 to 9 is there. 1 is very fit, 9 is terminally ill. Based on the, you can score the patients and assess the frailty. Higher frailty score, higher the chance of postoperative complications. And another one is a modified frailty index, which use 11 variables like functional status, diabetes, COPD, pneumonia, heart failure, myocardial infarction previously, etc. So this also assess the frailty score, and this is like 11 score modified frailty index and 5 score. So it assesses the scores based on the presence and severity of these variables. So higher score are associated with higher morbidity and mortality in all surgical specialties, including carotid revascularization, aortic canals repair, etc. in vascular surgery. So overall, these tools, how it helps us, it helps the clinicians to assess the level of frailty in older adults undergoing vascular surgery procedures, and it helps the healthcare providers to take a decision or tailor the intervention and treatment according to the frailty score and prevent any or delay the adverse health outcomes. So it improves the quality of life of older adults also. Thank you.